Good morning, and I'm going to call to order the May 31st, 2023 Board of Health meeting. And we are going to adjourn to executive session for up to 15 minutes to consider the selection of a site at the acquisition by real estate by lease or purchase in compliance with RCW 42.30.110. One page. Right, that's adjourned.
Do you know this one?
I said 15 minutes.
Thank you.
morning.
Ready? Okay, we're ready. All right, thank you. We're back and we are at introductions of guests.
Okay, so it doesn't look like we have any guests, but we do have two staff members that we want to introduce to you. The first one is Gabriela Alvarez. She's currently our accountant and has been with us for some time, but she's just been promoted to the program manager. And so she'll start officially tomorrow. So she'll be overseeing the breast and cervical health program and the developmental disabilities program and eventually the front desk.
Thank you. I'm excited to.
And then we also have Andy Wilson, who is currently an environmental health specialist with us, and he has taken the role of the local emergency response coordinator. And
Right.
so he will officially start tomorrow also.
Thank you.
Excited to have them both in their new positions.
All right.
Nathan's spot, right?
Yes. Yeah, and Andy comes, so he's an environmental health specialist, and before he was at the Department of Ecology. He was the lead spill responder and safety officer for the Department of Ecology.
And actually, Andy's been very helpful with our current incident command response. His knowledge has been really beneficial for us.
Andy, is it okay if we call you Nathan for the first few minutes?
Might happen.
Little Nathan, not Nathan.
We're gonna move into public comments.
And there were no public comments submitted for the board meeting, and we want to be public, so we don't have any comments.
Thank you. Now we're at consent agenda. All items listed below are considered routine by the health board and will be enacted by one motion. There will be no separate discussion of these items unless the board member requests, in which event the item will be removed from the consent agenda and considered in its normal sequence of agenda. Does any member of the board wish to remove an item from the consent agenda? Can you read them, please?
April 26, 2023, Yakima Health District Board of Health meeting minutes. Payment of accounts payable and payroll issued in April 2023 in the amount of $742,035.80.
Thank you. We need a motion to approve.
Motion.
We have a motion to approve
I would second that.
and a second. All those in favor, please say aye.
Aye.
Any opposed? Right, the ayes have it and motion passes. Thank you. That moves us to the Yakima Health District spotlight. And Ryan, you're going to take the floor today?
Yes. Yes, so actually, everyone in the management team will have their part.
Okay.
And what we're gonna do is we're going to talk about mandated public health services at the Yakima Health District. Next slide. So we're going to talk about the different laws and regulations that pertain to public health and in particular in local health jurisdictions. So this is a review for a lot of you, but we'll go ahead and go over it. RCWs are revised code of Washington. So these are permanent state laws that are enacted by both the state legislature and the governor. And then we also have the Washington Administrative Code, which is also referred to as WAC. So these are regulations and codes that are created by the state agencies. So a lot of the ones that we deal with are ones that are through the Department of Ecology, Department of Health, or some of the state agencies that we cover here at the Yakima Health District. Next slide. So what we'll be talking about is in particular is WACs and RCWs that deal with communicable disease, environmental health, vital statistics, and tobacco. And so next slide, and we'll go ahead and have the different directors talk about the WACs and RCWs that pertain to their programs.
So public health looks different across the country as far as health officers and being ran by a state versus local health departments. For Washington State, each local health department or local health district has a health officer, ours being Dr. Bard. He has duties that are outlined in the reference WAC that are up there, but in summary, the health officer is largely responsible for controlling communicable diseases, ordering isolation or quarantine, implementing emergency measures, case investigations, and it's the role of the health district to support the health officer in that. So Dr. Bard doesn't do these duties daily, but rather it's delegated to the staff of the health district, including environmental, public health nurses, front desk. It's all delegated through our staff to carry out these duties. Next slide. Okay, communicable diseases. There's a lot of communicable diseases, which is just the spread of disease from person to person, which is kind of listed on the right-hand side up there as your common communicable diseases, but not all of them are reportable. So the common cold is a communicable disease, but not reportable as a notifiable condition. But under the referenced RCWs and WACs up there, you can see that our role for communicable diseases that are reportable is investigation, testing, emergency orders, isolation, quarantine if needed. Next slide. This is a list of our notifiable conditions, which is about 100. They're not all printed on that picture up there, but under the referenced RCWs and WACs, it is our duty to inform healthcare providers, hospitals, and labs about reporting requirements. So every laboratory, physician, hospital is mandated to report to us certain communicable diseases. And then we also, when we receive those reports, we review and we take action. So our nurses get those, we investigate and to try to determine source of infection. And then it's our role to notify the State Department of Health of those through the Washington Disease Reporting System, the WDRS. Next slide. We have a couple of larger programs, which is our sexually transmitted infection program. Under that one, we examine, investigate, we treat STI cases. We refer people for treatment for HIV or AIDS. We also do HIV testing and provide court-ordered services. There are several different disciplines within law enforcement and a few others that if somebody is exposed to a bloodborne pathogen, the health officer can write an order that goes up through the courts to mandate the specimen on the individual that was, that exposed the other person. We also do tuberculosis control. It's our role to maintain records and case manage all active TB cases in the county. We provide treatment and case management for all of those. Next slide.
All right, so we'll transition into environmental health. Next slide, please. Thank you. So here we have our most foundational or fundamental programs in environmental health that we work in every day. However, there are 20 different mandated services that are related to EH. So there are some subsets to each of these fundamental services that we provide. As you can see, there are several different RCWs and WACs that refer to each of these programs, which address the different subsets of programs within. These are the minimum requirements and the guidelines and how we conduct our work every day. We are referring to and implementing these codes in our work every day in our programs, how we carry our permitting processes or our inspections through from start to finish. So how we implement these is there's several different requirements in each WAC. For example, in our on-site sewage program, to get a septic system installed, there's many different requirements that happen along the way. It starts with a site evaluation in which the local health jurisdiction determines the suitability for a septic system in a given location. We then have to oversee that these systems are designed and installed by licensed professionals. And then we go out and verify it was installed according to design, and we are required to record the proper documentation so that the future development of that property everything that's in the ground, kind of out of sight, out of mind, is recorded and accounted for moving forward in the future. And this is all in place to promote the health and safety of the public and the environment, that we're safely disposing of wastewater, for example. And that's what all of our WACs do, is how we can conduct, how businesses and people in a community live and conduct their work, and how we oversee that to promote a healthy community. So that's what we work off of with our WACs daily. Next slide, please. So we also have some other mandated services that don't get talked about as much. For example, we also oversee the decontamination of illicit drug sites or legal drug sites. Years ago, meth labs are really popular, and during the cleanup process, we were the agency that oversaw that a licensed professional company was would go in there and decontaminate the site. We would look at the test results to make sure the residuals were below cleanup levels, and then make sure the proper information was recorded on the titles of the property. Notifications to public went out, and people were not entering that site during the cleanup process. So just an example of some of the smaller mandated services we conduct that just don't get seen or talked about as often.
Sean, what's on schools? What role do we play with schools?
So one part of it is we do the food safety inspections of our schools twice a year. The other part of it is we review plans for school remodels, building new schools. So we review all the plans for the health and safety components of that. For example, how a playground is constructed, is there so many inches of bark dust or pea gravel or whatever, so if someone were to fall, they're not going to get injured. We also look at noise and pollution factors for a school site to make sure that it's a conducive location. So,
Thank you.
yeah. Next slide. Okay.
Good morning. Vital statistics is mainly handled by our front desk staff. All those WACs and RCWs that Sean went over, they have to have some understanding for the fees that are associated. Many of those have fees associated with them. Understanding of that, the majority of their day is spent with vital records. They issue birth and death certificates. All of our front desk staff is deputy registrars. They are registered with the Washington State Attorney General. And so they are all certified. That gives them the authority to issue birth and death certificates. Currently, those certificates, those records are kept, the birth certificates are kept in the Washington, what they call WALES, it's statewide system, or sorry, Washington Health and Life Event System. And then the death certificates are in the online program EDRS, Existence Death Record System. There's a lot that actually goes with disposing bodies. They have to be registered by the funeral home and then checked off by the coroner, and then finally last by YHD before a body can be disposed. There's actually a lot of rules and regulations around that you wouldn't see going on. A lot of that we handle up front, and we try to keep that away from the family, and we work directly with funeral homes on a lot of those things. Also, all of that paper for vital records are state tracked. They all have individual watermarks, and they're all recorded with numbers. We track those individually, and we do a daily reconciliation of those. Last year, we were in 2022, we issued over 17,000 records, 8,000 birth and 9,000 death certificates, which is up from 2021. When we had 6,000 birth certificates and 9,000 death certificates. Currently, we are on track to have over 18,000 vital records issued for 2023. That concludes my part.
Okay, so for tobacco, on the next slide, at the bottom of the slide, you'll see the one RCW that relates to the health district in terms of what specific duties are asked of the health district, and that's in, again, the RCW 70.160, which establishes the Smoking in Public Places Act, which prohibits smoking in indoor and public areas, as well as require signage. So in that RCW, it specifically states that the health district is responsible for providing education on this law, as well as making sure that there is health education provided to the public related to risk related to smoking. In it does say that the health district may actually enforce provisions of this law by conducting inspections to make sure that there isn't actually smoking taking place in public places, and ensuring compliance with the law. In practice, it has been several years since smoking has been prohibited within indoor places. So we've really only gotten 1 or 2 complaints from the public about smoking in public places. And when that happens, we provide education, and usually that doesn't, it's never another call back to us again. What ends up happening with these other 2 RCWs, however, is that there is taxes that are collected on smoking and vaping products here in Washington State, and a portion of that funding is designated to go back to public health departments, including the state and local level. The way that the funding is distributed to local health jurisdictions is based on a formula that's based on population size. And on an annual basis, we get maybe about $5,000 to $10,000 of funding related to tobacco. So ultimately, what we end up doing is trying to focus on supporting our local businesses with updating their signage. For example, vaping was just recently included as part of that law. And so I'm just making sure that your sign is up to date to say no smoking or vaping to be in compliance with the law. So again, while it is not a big portion of our work, it's still important to make sure that we're following our duties. And that's how we support the local community with, again, more messaging on the health risks associated with smoking and vaping, and updating the signage to be in compliance with the law as it states.
My question was, do you happen to have, or Chase, do you happen to know off the top of your head, of the 10,000, which seems quite low, how much is spent on educating children on the dangers of vaping specifically, since that's?
Yes, thank you. I apologize. So that portion of that, it would be, well, we'll have to get back to you in terms of what the exact numbers are, but most of that funding should be for youth specifically. And in that similar vein with I'm not referencing right now, but there's also marijuana funding that goes to children specifically as well. So most of the education should be focused on youth-based messaging.
So no surprise when we legalize those things, use by children has skyrocketed in both marijuana and vaping.
And yes, and so that's where the funding does designate specifically youth-based prevention. Thank you for that clarification.
Is that prevention in the schools? Is it advertised in the schools or in the community in general?
Can you repeat your question? Do you mean
So
our work or
when we use the money for education, is that money used directly in through the schools or into the community in general?
At this point, we typically message to the community in general, but there are programs within schools that focus on conflict prevention as well. We work closely with them.
Thank you.
I think between those two questions, you probably answered my question, because I was really wanting to get at what was the nature of the education that we're doing as far as, helping things avoiding that.
Yeah, so any type of prevention messaging, again, per the funding, scope of work does designate youth specifically, and primarily. But there are things like the quit line, and that is to the general public. So there's a Washington quit line, so that wouldn't necessarily be just for youth, but that is for the general public.
So when are we getting on TikTok?
Exactly.
One suggestion,
Well, if we really want to talk to the youth, we gotta go to TikTok.
one suggestion for synergistic use of the funds would be, when I was in medical school and even now, there are clubs like the Tobacco Awareness Program where medical students go out to local communities to educate youth. Medical students are more youthful, so they listen better and so they can synergistically help. You guys can help fund things like, I know when I was part of that program, they buy models, they buy smoke machine like model things and the kids specifically where you target 3rd to 6th graders can be very effective in simulating how terrible cigarettes are, the things we got for vaping and whatnot, but I think it's a wonderful program. I know it's a nationwide model and it's something that the health department could take part in helping fund what was an already existing program in medical school, more than likely.
Working with PNW.
Yes, exactly. That'd be the idea. Tobacco Awareness Program is a nonprofit, I think that it goes around to all the different medical schools.
Yes, peer-based education has been very, very effective.
Quick, just last question on tobacco, I guess. We as the health district, we don't do like the undercover youth going into a tobacco retailer trying to do purchases and not get carded. Like that's Department of Revenue, or does anyone know?
Liquor control.
Liquor control. Okay, all right. We don't play any role in that. Okay, cool.
No badges.
No badges.
I don't know if I could pass for you.
Is
Thank
that
you.
the end of the remarks? Well, thank you for all the wonderfully helpful information. And we are going to go into agency reports. Oh, I'm sorry.
I apologize. They give me a little wrap up.
You have a little wrap up?
I have a little wrap.
Please go ahead.
Thank you. Apologies. I'll be in trouble if I don't. I'll be in trouble if I don't say it. Essentially, one of the reasons that we wanted to talk about mandated services is there are responsibilities that we have, even though we're an independent jurisdiction and in this state, we're a decentralized public health system. We nonetheless have responsibilities that we have to act, and that's critical because that's been part of the public health system from the beginning of public health. The laws were enacted to keep people safe. And so one of the things that we find, we talked about public health 1.0, 2.0, and 3.0, starting in really the advent of this department over 100 years ago. The idea was to save lives and not get people sick. Then the creation of the public health system was to ensure that people had things like access to well checkups and immunizations. And now we're talking about how to keep people healthy and well over the span of their entire lives. But the foundation of that are these mandated services. Next slide, please. And so it ties into our strategic goals. When we try to create the strategy that we could incorporate daily in our work, the question was, how do we do so? One of them is delivering mandated services, which was the point about our discussion. There are things that we have to do by law, and that's something that we take very seriously. But in doing so, we can create a foundation for increases in effectiveness through developing networks of community partners and certainly being able to do our jobs more effectively. Certainly with 30, 40, 50 years ago, I think it was harder to do this work because we didn't have computers. And so we've been able to become quite efficient at getting things done because we're able to provide more services more quickly to people in the community. But these are fundamentals that we do. It's also the basis of explaining to our staff why we do our work. We're here to protect people's health and safety, and that's something that we talk about often. Thank you. I think we're officially concluded.
We have officially concluded.
Yes,
Thank
ma'am.
you.
Thank you so much.
Now moving with the agency reports, starting with FD.
Yes, thank you for your time. I wanted to provide you with an update. We talked last month about moving forward with the potential purchase of a building. Thank you to the board for your commitment to our work and also for allowing us the space to search. Bless you. One of the things we've talked about is looking at options to expand our services as well. That was part of our discussion at our last board meeting, and we were really encouraged about the interest in moving forward, specifically into expanding services in the Lower Valley. We've also been looking at how to spend money well. We're stewards of public dollars. And so one of the things we looked at was options. One of the options to purchase in the building is the idea of actually renovating our existing space. And so we have spent some time looking into that. I wanted to discuss that with you. When the building was built, it was built in this office park. It really was built as an office space. We do have some clinical services here. But sometimes those clinical services butt up against our administrative practices. If you want to share anything, Melissa, but it's not ideal sometimes the way we actually have to provide clinic services. I don't think there was any ill intent when the building was designed and built, but watching our normal practices, we see that there's some space issues that we have. We have hired more staff and we certainly are encouraged by that, but we want to plan for the future by having more office space and more communal space where people can work together. We think that that might be able to be accomplished with renovations. So part of our discussion with the board is to consider potentially rather than purchasing a building, the other option is to renovate our space here internally. And then be able to use those other resources to provide more services in the Lower Valley. Again, the board has been interested in that. We'd like to talk about expanding services in the Lower Valley. And certainly this is a large geographic county with people who have needs in all of our cities, certainly in the rural part of our county as well. So I'm open to your thoughts. If you have questions for me, then certainly be open.
Well, Commissioner, excuse me, I would simply state that it seems to me that it would be more cost effective to renovate, and it seems like it would achieve a lot of the wins that especially Melissa, with the services that need to be provided and some more privacy. I think it'd be a better use of our hard-earned taxpayer dollars. And it seems to me that going forward with a purchase just doesn't seem to be as high a benefit as remodeling this current site. And then potentially looking to expand services, I think is a great idea.
Do you have any cost estimates for renovation at this point, what that would look like?
No, but we're not talking, I don't believe we're talking about major structural work. We might be talking about the idea of an additional bathroom. That certainly would be a lot of work. We talk about putting in plumbing and certainly doing some concrete work. But we don't think that we have to expand the building now in terms of the sides of the building. So structurally, I think we'd be sound. I would think we'd be in the hundreds of thousands of dollars, certainly. So I would think $400,000 to $500,000 probably. But the cost of construction is very high now, so I wouldn't want to hold. I don't think I'm expert in this, but at the same time, the cost of renovating internally would be far less expensive than purchasing a building. And the idea was that those resources that we save, we could use towards expanding services in the Lower Valley. The idea of expanding services means we could have more of a footprint in the community. If we purchase an additional building, we can also have to do renovations on that building. I do want to share that to be clear. We purchase a building, there would be regular upgrades like carpet and paint, but then we'd also be talking about security doors, security systems, alarm systems connecting to the county IT system like we have here. There really are additional add-on costs. So in a sense, we could be looking at $400,000 or $500,000 in that building as well. So by doing so, we can secure more space for our staff. I think a better flow for the way we serve patients, a more dignified way to serve patients in fairness, and then also be able to provide resources to expand into the Lower Valley.
It seems to me that if we purchase the building because it is more ready in terms of the kind of clinical changes that we'd like to see, still people would have to come all the way here for services. I personally am in favor of expanding the services in, a footprint in the lower valley to all the cities down there, that not everybody have to come to Yakima for all the services they want. I think it'd be far more conducive in terms of accomplishing the goal of the public health to be available in the community rather than having to have everybody come to Yakima. That's just my thought.
Keep having this thought of when we think about providing services in the lower valley of making it a mobile unit, and I'm not sure if this is a thing, but are there like retrofitted RVs that could be utilized to provide services around the county? Does FEMA have large medical things that it would be worthwhile for the health district to invest in that would allow you to have, 3 rooms or whatever? And also make it a more of a mobile unit. That thought just keeps resonating with me, so.
Sure. Well, one of the things I'd like to, after this discussion is talking about expansion of home reduction services, and we actually have cost estimates for that. So we already have purchased the RV, and so we're talking about being able to use that as additional day in the lower valley. There certainly are options to purchase.
Because buildings are expensive and they're always costly and those costs never go away, so.
Yes, so and there are many companies, clinics, hospitals that purchase large RVs that are like mobile hospitals. And then those can be bought on the secondhand market. I would want to buy something that was in very good shape because there's nothing worse than a vehicle that doesn't run. And I've seen that throughout my career too, where it's a dental van that doesn't run because the engine will, the air conditioning doesn't work. But at the same token, we've also talked about, and we discussed this pre-COVID, but things just didn't align, and that was having a footprint with other. So there's clinics in the lower valley that could have space, and we might be able to lease or even purchase with someone some space so that we have access to a location where we can provide services so that we can have our staff go there, have the same similar setup that we have here and provide the services to folks in the lower valley without having to own a building ourselves or provide the security for the building ourselves.
One of the things I appreciate where we're at right now is that we no longer have this time rush, and I think it gives us the opportunity to be very deliberate in how to move forward. Both with the idea of renovating the building here, and I think that makes a lot of sense. I can do that so we can get in a more efficient, more dignified manner for those that need the services, but also take a look at what are the real opportunities for expanding the services to other areas of the county.
Well, Commissioner Lindy, that's a great segue into our discussion about mandated services and also what we've been discussing for a few months, which is foundational public health services. The state has made a commitment, and again, the foundational public health services, which is a mouthful, is an investment that the state legislature is making back into public health after decades of not spending money on maintaining services. And so we have dedicated funding that will continue year to year. To your point about a time rush, we actually have money that has the ability to be nimble to provide resources that are fundamental to this work. Historically, government dollars are very categorical and they don't allow for flexibility. And so if we're able to expand services with dedicated funding, it means that we actually can have more staff, we can have more services, we can have more consistency. And again, our county is both rural and very large and has pockets of tremendous poverty and barriers to health success. So we want to be able to achieve improved outcomes for people. And we have to provide the services. To your point, Commissioner Curtis, we have to bring the services to people rather than expect people to come to receive services. It's fundamental that we are service forward and that we also are seen in the community. That's part of what we're discussing when we talk about things like tobacco and vaping prevention. When we're talking about services and changes, you have to be seen in a community and trusted in a community in order to actually create that relationship for people to change their minds. So I'm really grateful for this conversation. It will take a little bit of time if we're talking about renovation to come up with a plan. Again, in government, we follow policies. We have to get bids and then we have to get estimates, but we can bring that to you in terms of estimation. Also, in fairness, we're not at a point pivotally that we're in danger of running out of space. This is just for planning for the future and also planning for improved service. In terms of expansion into Lower Valley, there's some things that we can do, and at some point, I'd like to pivot to the discussion about the home infection program.
I think I asked this last time, but I forgot. The health district owns the land as well as the building. That is the health district's.
Correct.
Okay,
It's all paid for. It was purchased in, what was it?
2007.
2007.
right.
Well, let's move ahead in our department reports then, and we'll come back to that discussion if that's all right. Chief Operating Officer Ryan Lavac.
Yeah, so the two things that I want to discuss, and the first one has to do with emergency planning and preparedness. The first one is that we are continuing to be in incident command system. Our incident management team is activated for the subsurface fire at the DTG landfill. So we continue to work with the Department of Ecology, with DTG landfill, with their fire consultant, with our own fire consultant that we've contracted to look at data and advise us of how to move forward. And it's suppressing the fire, but and then also preparing in case there is an event of above ground fire, with the air pollution, poor air quality, how we're going to deal with that. So we continue in that mode. The second thing in emergency preparedness is our after action report for COVID. And so that's due to the state Department of Health at the end of June. And so we're kind of having a final copy of the after action report by the middle of June. And we'll get that out. But we did send a survey to all internally to all staff. We sent it to all the board members. So thank you for all the board members that responded to that survey, and then to all of our partners too. And so that after action report will have, how many people the survey went out to, what our responses look like. And so we'll be going over that in the next month or two. Once we get all that finalized. And then on the human resource part of it, since we have promoted 2 of our employees, we do have openings. So it's kind of a domino effect. And so we are actually, for both environmental health specialist and our accountant position, we have done interviews, and we should hopefully by next meeting have 2 new employees in the role. All I have.
Thank you. Then we'll move to Dr. Bard for a health officer report.
Well, just as the sharks never leave the water, monkeypox hasn't left the country. So it's been present at low levels after the big outbreak last summer. So there's ongoing case detection, and also wastewater surveillance still shows monkeypox in the wastewater in some areas of the country. So in April, there was an outbreak in Chicago of 13 cases, which they looked at closely, and a number of those people that contracted it had traveled to larger cities. New York City, New Orleans, or Mexico were some of the places that travel was identified. And interestingly, more than half of those people were vaccinated, some with 1 dose, some with 2 doses. So there's some gaps in the vaccine activity, and also the fact that overall, only about 23% of the at-risk population has been vaccinated. So with this outbreak in Chicago, there's worry that other areas of the country are going to experience the same thing, and not necessarily linked to Chicago. It could be separate from Chicago because of the low level activity that's present throughout the country. With the summer, of course, the risk of gatherings increases with outdoor concerts and plays and various graduations and other places where large numbers of people are going to get together closely. So there is a worry that it's going to pop up. So restarting the vaccination program might be a good idea. Nothing's come down that I've seen yet from DOH or from CDC, but the CDC publications are discussing that issue. And I understand we do have vaccine on site here that we can redistribute. I don't know how many doses though. Everybody's trying to find out. It's there, it's in there, it's inventoried in the refrigerator. So restarting that vaccine program would be one thing that could help keep things under control in Yakima County. The vaccine turns out it's good, but it's not 100% like almost any vaccine. And the best protection is given by the 2 doses. But even some of the people that were in that outbreak had 2 doses, but that was almost a year ago. So the vaccine immunity does appear to wane. And remember, the vaccine is actually directed specifically for smallpox. There is a crossover to monkeypox, but hopefully So people are living on a specific vaccine for monkeypox, which might be more effective than the current vaccine that's being used. A good thing out of all this is that very few cases have been reported in rural areas. So as of December 22nd of 2022, there were 29,980 cases throughout the US that have been reported. But 440 of those cases were in rural areas. 1.5%. So that's one good thing working in our favor. The vaccine gaps need to be closed, which we do setting up the program again. And then look out for new cases. So we need to do a provider alert saying that this could be happening. And that even if people have been vaccinated or had monkeypox before, they could still get monkeypox due to waning immunity from either event. So the information dissemination is going to be reported. And that's pretty much it for a review of monkeypox. It's not great news, but it's not horrible news. One one little story I want to tell, Melissa and I were talking about this the other day, is the effect of education. So we've had ongoing increased cases of syphilis, gonorrhea, and chlamydia. And it's pretty common for people with risk factors to come into a clinic complaining of one disease, but also being tested for other diseases at the same time, because they travel together. So there's been a long time, there's been a program, say somebody comes in complaining of symptoms that would suggest gonorrhea or chlamydia, that they get tested at 3 sites where there's commonly infection for all 3 STIs, is sexually transmitted infection. And also for HIV and an RPR, which is a syphilis test, be drawn. And in the emergency room recently, a patient came in with symptoms of a sexually transmitted infection. And the other 2 tests were drawn, the HIV and the RPR. And it turns out the patient was RPR positive, meaning they had syphilis, and also was HIV positive. So we had recommended to ERs and other clinics to do test and treat. In other words, if you suspect that they have a STI, you get the test that you need to make the diagnosis, but you advance the treatment ahead of time. Many of these people won't come back. If you say, hey, you know, you've got syphilis, we need to give you an injection, they won't come back. But when they're there, you treat them. So this person left the clinic, left the ER, already treated for syphilis infection, which means he's not going to spread. They also test for hepatitis C when there's risk. The major risk is previous history of injection drug use or active history. So the education from the health district was disseminated to the local clinics and emergency rooms, and it's working. So the provider alerts, also personal contact. These things help a lot. So good story. That's it.
Thank you, Dr. Mark. Go ahead.
Dr. Barg, I just want to mention, I was recently ran into the ED director at Sunnyside Hospital, and he was quite alarmed with the spike he saw in syphilis cases. That sounds like you're aware of that. On top of it, he wanted to make sure that I let you know, but it sounds like you're there. But he said 50% of the tests they're running on in those cases are coming up positive for syphilis.
There's one day last year where the DOH case tracker person had 90 active cases. So
In Yakima County?
just in Yakima. One good thing though, with all the education efforts, we had a big sort of surge in congenital syphilis cases, and I hadn't heard about it in congenital syphilis case for my entire medical career until a year and a half ago. But with test and treat and more education to the providers, they're actually the case rate is very much reduced now. So yeah, we're working hard on it.
We're about a year and a half into our syphilis outbreak. At one point, we were up almost 400% in syphilis cases. So we're working a lot with our Department of Health Disease Intervention Specialists. This current outbreak, previously it was more associated with men who have sex with men, but this outbreak is associated with our homeless and drug using population. So it's a very difficult population to reach, which is why in our harm reduction program, we have nurses out there who are testing and treating on the spot if they're positive to try to get ahead of this outbreak.
I'm just trying to recall, I know we talked about monkeypox last year, during that in the specific population that was prevalent and then the mode of transmission. Could you kind of go over that again? Because you were talking about gatherings coming up, concerts, things like that, which really wouldn't be applicable to monkeypox, would it?
Well, not everybody has noticeable case of monkeypox. You can have like 2 or 3 lesions, not even know they have monkeypox. So if you're in a situation where there's skin to skin contact, for not just briefly, but may say a few minutes to more than a few minutes, there's a chance of spreading it in that fashion because the blisters that are there are full of virus. And if one of those happened to break and get on the clothes, skin contact with contaminated clothing can spread it as well. Skin to skin contact can spread it. So if there's a few people at a large gathering that have it, a few other people may get it from each of those contacts. So one person might say spread it to 3, and then the next week the gathering might be going where those 3 people have it and they spread it to 3 more people or 5 more people. So it can move pretty quickly, not like COVID, but it could still occur in populations that are at risk because they're at risk because there's other people in that social group that may have monkeypox.
I think what Daleen is getting at is a targeted message. People who go to a concert at the Gorge are not particularly at risk. Now, if you decide to go into a tent with a few people and have close skin contact for several minutes, that might be the behavior that puts you at risk. So I think a targeted message is probably what she's
Well,
driving at.
yeah, just not putting this out there in the community like, oh, everybody's at risk and this is going around. Because what I recall, like from the CDC side is I mean, they made it sound like pretty much it has to be almost like in a sexual encounter with that close of contact, skin to skin for a prolonged period of time is the way they made it sound. So even
Right, it's not a brief contact, it's a sustained contact. And one of the activities that has sustained contact is sex. But there are other ones.
Ms. Ackerman, we also spent a lot of time working last year with our communities that support people who might be at risk. And so we're really fortunate to have that kind of connection. I don't know if you want to speak to that, Melissa, but we actually did go directly to people who supported those who were most at risk and speak to them about communicating safety and choices and getting vaccinated. And that really helped a great deal. That's not the case in every community in Washington state where there's that connection. I guess my thought was just putting out this general message that the public at large is gonna, it's gonna create the situation where people think, oh, I need to go get a monkeypox vaccine, and not everybody needs to do that. We don't need to mass vaccinate the community.
That's correct. And the vaccine efforts are targeted. You're absolutely right.
On that note, what was the total monkeypox cases we had in Yakima last year? Like, was it 6?
Yeah, I want to say it was like 6 or 7. It was quite small.
And I know the health district did a really good job of reaching out to the vulnerable community folks that could potentially be exposed, and there was a lot of vaccination. So can the health district go back and make contact with everyone that was vaccinated last year? Like, is that legally allowed to say, hey, you're still at risk, please come in and get a second redose of?
Yeah, we didn't actually administer the vaccine. We provided the vaccine to the clinics, specifically New Hope, because that was the first targeted group was individuals who are positive for HIV. But definitely something we can go back and educate. We're working on determining how much vaccine we have on hand, making sure we don't have any expired, and then going out and offering them getting at least a second dose, if not.
Because the health district has that data, right?
Yeah.
We know who we vaccinated last year-ish.
We would have to go back to the clinics
That's it.
and have them run their reports, but they can do that.
I think it's still just, the targeted, when the individuals are not, it's the education for a targeted group of people who are highly likely.
Well, the other exciting thing that we're discussing and what Dr. Bard mentioned previously about syphilis is it's not just educating community members who might be at risk, but it's also educating our partners, our community partners and our clinical partners about best practices. And that actually came out of one of the things about our provider resource website. We talk about it often here, but years ago, that didn't exist. Tacoma Pierce County created one, and then with Foundational Public Health Services, we asked to be a pilot program in Eastern Washington to replicate that for us. It used to be that clinicians, nurses would have to call after hours to get information directly from a nurse, who would have to then wake up potentially, call them back, give them information. It was a one-to-one communication, which wasn't effective. We've really created an efficiency by being able to share that information and have protocols available online. So that's the provider resource website, which is exciting for us. So to the point about being able to educate clinicians about the importance of perhaps revaccinating, those are the things that need to be done.
Melissa, looking at the epidemiology or source tracking for syphilis, are you seeing a more virulent form of syphilis, or is have you found any data that would suggest why you saw a spike, compared to normal nadir levels of syphilis in the community?
And no, we have, the State Department of Health is working on getting us some GIS data to actually target a certain location within the county that might have more syphilis cases going on. We know it's within the homeless and drug using population, but we're really trying to be able to target in and see. But the other complication to this is that the treatment for syphilis is an injection, at least one injection, up to 3 injections of bicillin. And there's a national shortage of bicillin right now. So there is an alternative treatment, but it's taking a 2-week course of pills. And so when you're working with a high-risk population who may not adhere to the regimen for treatment, it can be difficult. So we're really trying to balance that act too, and making sure that the injection is being used for our pregnant women first, and then other high-risk population.
And Dr. Bark, follow up on that. Is there any drug resistance in the syphilis that we're seeing?
No, there's none.
That's good news.
Yeah.
On syphilis, I know for like HIV, we have rapid testing where you can literally know results in 15 minutes. For syphilis, we don't have such a thing. Syphilis
Yeah.
tape, we do. Okay.
Yeah, we are a pilot with Department of Health.
Right on.
We're the first one doing it. So we're doing rapids out in our harm reduction program. Because we know that's the population that we're seeing it in. So with our nurses out there, when they have a positive, which they've had, they just treat them on the spot.
Awesome.
That's one of the reasons, because the incidence is so high. That's why test and treat is effective. Don't wait for the test to come back. Yeah, so maybe you wasted bicillin. You're still, the overall effect is positive.
All right. Good discussion. Thank you. Let's move on to financial report.
Right, good morning. If you're in the board packet, click on page 1, it'll also be on the screen as well. I'll try to go through this fairly quickly, so if you would like to go ahead and interrupt. We had a monthly gain in excess revenue of approximately $178,000, bringing the total year to date up to $804,000. For the allocated budget for revenue, about 3.3, and actual revenues coming in closer to 3.6 million. Expenditures, 3.4 for the allocated budget, and actual is coming in at $2.8 million. Any questions on the summary sheet? Okay, next page, the income statement. Again, I'm going to be moving quickly, so if you want to interrupt, please do so. Our eye grabber of the month is with our developmental disabilities program. You see over there in the monthly column, we had a big uptick in actual revenue for that. Lillian will speak a little bit more to that. We're at the end of a biennium grant, and we're starting to see additional monies funneled towards our providers. And again, Lillian will speak a little bit more towards that. Any questions on the first page of the income?
I do non-governmental contributions of $10,000. What was that?
Oh, that was for our Everyone We Can program. Where we have an additional 10,000. I guess Lillian could also speak a little bit more towards that too. It's for our BCHP program, or breast cancer health program, or
Yeah,
breast
yeah,
and
I
cervical.
Yes, so Everyone We Can is a foundation that's based out of Spokane County. When we began to administer the breast and buccal health program in Spokane County. The grant dollars that were originally provided to the Spokane Regional Health District through that foundation were transferred over to the health district. And so those grant dollars are to support funding for people that don't fall within the BCCHP program, which is a specific age range. So it's basically extra funding for special circumstances for women to receive breast or cervical cancer screenings. Thank you.
Any other questions? Next page. This concludes our income statement. Any questions regarding? this last page? All right, moving into program sections on this next page, on page 12. Down towards the bottom, you'll find the tobacco and marijuana programs where we're spending in that year to date. So we are on the far left is actual current month's expenditures, and the middle column is our year to date expenditures. Then you're seeing we're spending a little bit more than that than what our grant is. We have some flexible dollars that we've allocated to some of those programs to help alleviate any overages that we might have in that.
Page fingers and magnifying glass.
That would be helpful, huh?
A little cross-eyed right now.
And the last page of programs, up towards the top, 852, it's supposed to be peach. There's the every woman can piece. And so we've had a little bit of expenditures for that. We'll spend up the remaining $5,000 in the months to come.
451 solid waste nuisances, what is that?
So that solid waste is more or less our garbage, our landfills.
But this isn't like KN and DTG issues, is that where we're tracking it?
That's part of it. A lot of our EH, environmental health specialists, are coding their time to that 451 when they're dealing with that.
Okay.
A lot of the administration is actually 454, which is in the foundational public health services.
451 also covers solid waste complaints from the community, so houses that have excess refuse and trash that, will send notices to property owners to clean up and follow up with that effort. So
Right on.
that's what we code that time to, and it's mostly covered by our grant through Department of Ecology.
Right, yeah. Historically, it's been mainly complaints that have come in. Lately, it has been heat and the DTG issues.
5060 hazardous cleanup, what was that?
That is two parts to that. If we have any, so if there's like a meth lab, a drug lab, and EH has to go out and do some inspections for that, to clear it. That's what people put their time to. But there's also Yakima County's effort to clean up homeless camps. We're help fund that piece. That's where the expense for that is coming through as well.
Illegal camps, they're just illegal camps.
Illegal camps. Mhm. Abandoned illegal camps, yes.
Yeah, I mean, we recently had a drug lab cleanup that was kind of complex, so there was.
Is it meth?
There was residue of, yeah, we don't know if it was manufacturing or use, but there were seeds that were chemical. In a structure, so we had to oversee the cleanup of that.
Retro. The old is becoming new.
Any other questions for programs? The next page is our COVID expenditures. We would date 22,000. Let me see a slowdown in the expenditures. Last page is our cash flow for the at the end of April. We're gonna have total cash and cash equivalents about $4.3 million. We're starting to actually see a downtick in our overall cash equivalent will downtick again until July, where we'll get $500,000 for flexible dollars, and we'll probably have an infusion of PHS money then too. So expect uptick in cash equivalents in July. There's no more questions. That concludes my report.
Thank you, Mr. Gordon. We will move into the control conference and secretary.
I want to speak on when we get into Chris's agenda item as well as our reduction expansion, but something that I'm going to add now is We made the map again, there's currently a national outbreak of salmonella in 31 states. And Yakima County has 2 cases, so they're linked to backyard poultry. So this is part of what our public health nurses do. They call and they ask questions based on which disease it is. And so we provide that information to the State Department of Health. They provide it to the CDC. And then as they find that there's multiple cases, they do genotyping on these specimens. They find that the DNA is linked together. And then by looking at all the answers on the questionnaire, they could determine this was likely from backyard poultry, also one from raw cookie dough. But that one, we don't have any cases, so, but we do have 2 cases of backyard poultry. Salmonella that are linked to the outbreak. That's all for me.
Thank you. Environmental health, Sean McGee.
Good morning, everybody. We continue to work closely with Yakima County and state agencies with our efforts in the groundwater management areas for contamination in groundwater. There's some money coming our way through the state legislature, well, in partnership with the county, to do some more work in the Guamo that there's a lot of work that needs to be done there. So we're working with public services and ecology and Department of Agriculture on how we can get creative with staff time and availability to carry out some of the outreach and education and testing of wells within the Guamo. That money is hopefully useful. So continue to update on our involvement with that effort as it progresses. But we're in the kind of planning phase of that right now. Also continuing some more work in the EC area for PFAS contamination. We're partnering again with state agencies, Department of Health, with kind of organizing and reaching out, trying to get people set up with some resources to alleviate their exposure to PFAS, that people who are under the federal limit but over the state action level. And this gap where the federal government isn't able to provide resources to those folks. So we're trying to fill that need with either alternative drinking water or filtration. And then we're also doing follow-up to make sure that these resources are being effective for these people, such as a water sample after a filter is installed. So we're working on that too. We got our first couple households set up with filters, and we'll be out collecting those water samples shortly. As many may know, we're really busy in the solid waste program. We're approaching some renewal deadlines for our limited purpose landfills. We've received a lot of documentation and plans for review. So we're working closely with the Department of Ecology right now. And working collaboratively with our landfills to provide them updates for any revisions that may need or more information we need from them to get those plans approved. So hopefully we're at a spot later in June that have all the renewal documents in order and in place so these landfills can move forward with their new permits. And then as you all know, we're also working on the subsurface fire at DTG. So we're conducting daily ambient air monitoring that DTG's consultants, environmental consultants are pulling those samples daily and sending the data over to health districts for review. So far, ambient air quality is good. There's been nothing hazardous coming out of the landfill, which is great news. The data from inside the landfill is still showing that the fire continues. So we're working with DTG on a suppression plan and making sure that the implementation of that plan is done so safely. We have concerns, heavy equipment with steep slopes, how do we prevent a slope failure from occurring in a massive release of emissions, or the dangers of somebody falling into a sinkhole or a crack or something it's very real. So we're taking that into consideration before we implement an action plan.
I saw in the last incident report that the health district purchased 5 gas meters.
We purchased 2 5 gas meters that are portable.
Oh,
So they measure,
But these aren't like installed at the site that will be
No.
permanent.
these are for staff who go on site. They measure volatile organic compounds, which is, the general range of gases that can be hazardous. Carbon monoxide, hydrogen gas, lower explosive limits for. like,
Did we ever determine the root cause of why the fire started or anything of that?
It's a landfill.
Is that just normal? Like,
They're always on fire, so we can explain.
except the county's one. Ours doesn't seem to be on fire.
Don't say it out loud.
We're gonna stop that.
Yeah.
We haven't pinpointed exactly what caused this subsurface fire. I mean, unlike different situation than the fire at the other limited purpose landfill during the winter, this one is, covered and, but still, not inhibiting oxygen from coming into landfill. Anytime you have ambient oxygen levels and, rapid decomposition, you generate cause combustion. So that is a likely cause, but again, there could be other contributing factors, because we are seeing gas emissions that are related to combustion of petroleum products, so. More investigation will tell us, more in the future, but that will come once the fire is extinguished and through Department of Ecology's MOCA process that is activated for the site. The fire is just hit the pause button. So
Gotcha.
we'll know more once we're able to move on from the fire and the Department of Ecology can carry out their MOCA investigation.
And I should mention also, Commissioner Curtis, when you're discussing what potentially goes in a site, Department of Ecology tracks things like that. So if something's petroleum soaked, it actually has to be tracked by Department of Ecology. So there will be an historic investigation of some of those additions to the landfill.
I just want to thank Sean for bringing up too that, when we hear about it, we expect, well, why don't they just put it out? And you just very well articulated, there has to be a plan and the plan has to actually involve a lot of folks who are considering all the different impacts of, you don't want to make the problem worse. And so I think you did a great job of articulating why you have to work with ecology and come up with a plan that when implemented isn't going to exacerbate the issue.
Yeah, it's site safety for staff and workers and then safety of the community around the landfill, a priority.
Wrap it up.
Yes.
Thank you. All right, then let's move on to public health partnerships, Lillian.
Thank you. Well, I'll start with that explanation that Chase was referencing. So as you all know, the Yakima Health District administers the Developmental Disabilities Program for Yakima County, and that's through a contract with Developmental Disability Administration through the state of Washington. And so what's been going on over the last few years is that a portion of our program, which is supported employment for those with developmental disabilities, a lot of that program is administered through subcontractors. And statewide, those subcontractors for supported employment for those with developmental disabilities have voiced serious concerns about their reimbursement rates that they've been receiving. And what that's been causing is that several supported employment providers across the state have actually had to take the decision to no longer provide those services. And so as a response to that at the statewide level, there's been some advocacy around increasing those reimbursement rates and providing some other solutions to make sure that those organizations can stay in business and that until a long-term solution can be found. And so that's what that influx of funding is the state legislator actually did approve some additional funding. It's temporary, so it's not a long-term solution. But that is what we're going to be receiving the next few months is essentially more funding to help make sure that these providers can stay in business and give the state more time to come up with a long-term solution for so that we can make sure that those services are available to those in our community. And the other update that I have for you all is that we'll be working with the Yakima Valley Office of Emergency Management over the summer to make sure that we have an active push on messaging for Alert Yakima. Alert Yakima is our emergency notification system here in Yakima County. So we'll be working on increasing our messaging and making sure there's a stronger presence. There's lots of events coming up over the summer, so making sure that people are signing up for that. So I encourage all of you in your platforms to also encourage people to sign up for that emergency notification system. It's very easy to sign up for. You can go to the website, Yakima County, and sign up for it in that capacity. And Yes, so those are the updates I have. Any questions?
I'm hearing none. Thank you very much. Right, so under unfinished business, we have none, but we actually have some. Sorry. I didn't write it. So we have some ongoing discussion about our harm reduction program.
Yes, thank you. So we had talked last month about the opportunity to expand potentially in other areas and come up with other board members and have interest in expanding our harm reduction program. So we again have been successful with the purchase of our vehicle. We've expanded services. Melissa has touched on some of the services we provide with nurses and other staff. It's a whole array of services that we're providing. We had looked at doing so before COVID and we're doing so in confidence. And we can go through some of that because I think it's important to understand the history of that. But what we did since our last meeting was look at the potential for expanding that program to Willow Valley, and the number of staff it would take, how much time it would take for them, and then the cost associated with that. And so we'd like to bring that to the board's attention, with the understanding that we still have to build the program and find a location and work with it. But Melissa, do you want to chat about staffing and so forth?
Sure, do you want me to speak to the cost piece or just the staffing?
So I think about cost.
I believe for cost, we were looking at 3 people at a 0.05 FTE, so maybe like just 4 hours a week. We were coming, it was some mileage and about $8,000 a month is kind of what we're coming close to.
So we're thinking anywhere from about $60,000, $60,000 to $70,000
Annually.
Program.
Yeah.
That would allow us to expand to the lower valley for 1 day a week for 3 hours. That could mean like we stop in Toppenish and then we go to Wapato. We don't have to spend the whole 3 hours at one specific location, but it would allow for us to have 3 staff out there for the exchange of the syringes, but also for providing Narcan, case management for treatment, testing and treatment for STIs. Our whole, we would continue all services that we have here in Yakima for the expansion.
Just a question, but if Chase's number's right, that 3 or 8 times 12 is 96,000.
Yeah, I don't think.
No, we came up with about 60,000, and that would include mileage or gas.
Yeah, the 8,000 was just for the whole year.
So I think expanding the access to services for the health district in the Lower Valley, I'm supportive of, but the harm reduction services and exactly what those are, I think deserves greater debate. And whether or not we're going to offer those out of a mobile unit, specifically the needle exchange, I think, and the Narcan is something that we have to address. Our community members are very concerned about it. And I think that, expanding, just going out and saying we're going to expand this without having a real discussion about it is something that I'm in favor of. We need to talk about this as a meeting.
So I'm sorry, you're in favor of expanding it and talking more about the value of.
I'm in favor of the idea of having mobile services for access to the health district. I'm not in favor of expanding the needle exchange program. I think we've talked at length about this, but we want to have people intervene with someone who's going to be able to provide them with confidential services to hopefully change a behavior. And I think that the easier we make it for someone to come in and continue that behavior without having a true intervention, because I don't think it's intervention to have someone handing out free needles through a window. It's not going to change a behavior. And that is my concern. I want people to be able to have true meaningful conversations with educated professionals who are going to actually get them off these addictive drugs and making poor decisions. It's what leads to all of these other problems that we have in our community, not only health wise, but crime. what children are exposed to, and we saw this heightened during COVID. I think that probably COVID was a lot to do with why we saw rising in domestic violence and drug abuse, and STDs. So I just think that, you know, if we're gonna talk about expanding services, I'd like to do a gut check on what services we're talking about expanding.
We actually have a partnership with Comprehensive and Triumph Treatment Services. So every week we go out there with lived experience that are developing a rapport and talking to these people about getting treatment. And they're there to get them linked in when that person is
We've
ready.
talked about this before, and what we're lacking though is tracking. So we need, if we're going to spend money on a service that is meant to, is the goal to actually help them get off drugs? Or is it simply to enable the addiction?
The
And
goal
that-
is to keep them alive and keep them as healthy as we can until they can make that decision to get in and get help.
We have to be responsible with taxpayer dollars as well. How long are you going to provide a service to someone? How long are we going to do that before we actually say, listen, you know what, before we do this, we really want to get you in to talk to Dr. Bard one-on-one and actually talk about what are the driving forces? What kind of more extensive counseling can we get to you? Are there financial resources that you need to help you get to work that are keeping you from being able to make successful decisions? I think unfortunately what we've done as a society is we've removed all intervention, and it's the same root cause of the drug possession law. The idea is that we don't want to criminalize drug addiction or addiction to anything, absolutely. But what we do need is to intervene in a way that actually provides a carrot and a stick to be able to say to someone, look, you're going on a course that is going to unfortunately either end up, you're going to die, which we don't want, or you're going to cause irreparable damage to the relationships and people and public health along the way. We've got to find a way to intervene in a way that these people, we're not tracking it. We have no idea how successful these programs are as far as getting people off of making harmful drug addictive choices.
I'd like to level set on a couple things. This program is not about enabling addiction. There's a twofold purpose to what we're attempting to do. One of them is to reduce the spread of disease. These are communicable diseases. Dirty needles spread disease to people that then makes them very sick. There's a huge cost to them personally. There's a huge cost to society. The other is that we're looking to allow people, as you said, to access services that can move them towards not having an addiction in the first place, which is very critical. But the issue has been here for many, many years. My concern is this is a community with many, many barriers. Needles on the street, we don't want. Needles being allowed to hurt municipal workers who have to clean up garbage, we don't want. We don't want children learning about intravenous drug use by having playgrounds.
No, they're going to learn about it because it's happening inside of their home.
Well, we're not an enforcement agency when it comes to the choices that people make. What we're trying to do is reduce the actual diseases that imperil people and allow them access to more services. We've expanded those services. We were only doing work with Comprehensive. We expanded that to have a relationship with Triumph. But these issues are prevalent in our communities. They're certainly prevalent in some of our lower valley communities. So what we're trying to do is allow people to access the services so that we don't create more problems for them and more problems for this community.
We're creating more problems for society. It's everywhere. So the referral program, if I recall correctly, there were over 4,500 needles that were distributed on an annual basis for about 5 years is what the data showed. And over that time, 11 referrals. 5 years, 11 referrals of those people to treatments.
No, the referral when we haven't had comprehensive out there for 5 years. During COVID, they weren't able to come. The 11 referrals were over a 2-month period, and those referrals were people who actually got admitted to the program at Comprehensive.
Over 5 years.
2 months.
Let's look at the data again, because we talked about it. And that's why I specifically said we need to look and track these, because again, if this is a program, we're working so hard in our youth coalitions to try to prevent drugs, and yet we're out there we're not solving this problem. I think it just simply warrants saying this isn't preventing people from making addictive choices. So how, to your point, we have to look holistically at the root cause, because it isn't just preventing someone to get, a sexually transmitted disease and or hepatitis and the cost to the economy and the hospital and all of those. We're also, though, creating a society that is crumbling around us. And we have, how many hundreds of thousands of dollars are we spending to clean up all these encampments? We're dealing with all of the crime. Unfortunately, the biggest thing is that we're exposing children to these behaviors, which we're creating these adverse childhood experiences that only perpetuate a problem. So in the future, we're going to have, these children are going to grow up and they're going to be more likely to have these adverse experiences or make poor choices as well. I'm just simply saying that I want to see us track it better and actually have the true goal of how do we get meaningful intervention in a way that are going to get people off of these addictive drugs versus handing them needles so that they can continue to go out and use drugs without having, they know they don't have to have a meaningful intervention.
I would counter, oh, I'm sorry.
Well, I was just gonna say, I had a negative stigmatization of the harm reduction program until I actually spent a few hours out there and saw it in action. And one of the big things that that I take back from that experience was, one, is that comprehensive health individual or whomever that provider was really heavily engaged in conversation with every single person that was taking resources. These folks weren't just coming in, grabbing and leaving. I mean, she was heavily leaning into them, saying, hey, you said last week you were going to do X, where are you at? Trying to hold people accountable, which made me feel better about it. The second thing about the harm reduction program that always sticks in the back of my mind is it's not just the typical homeless individual you think is showing up. It's every walk of life. There are people in our community who have cars that are showing up, participating in the needle exchange program or utilizing those resources. And so one thing, Melissa, I had in the back of my mind is we are tracking. There's lots of data that are being tracked at least 2 months ago. So
Yeah.
from that data, are we seeing any net positive outcomes that to your point, Commissioner McKinney, that we can lean into as far as what is the success of harm reduction?
And I do thank you, Melissa, because that's what came out of our conversation last year, is wanting to track it. So
Yeah, and we've been tracking it. I know I reported on it, I think in February or January. I know you weren't here at the meeting, but I did report on how many people that it, and I think actually you had commented that you were happy to see how many people were actually being referred.
yeah, it was
Not
5
sure
when
at the time.
previously we'd had 5 for the whole. There were
Yeah,
5
it's
folks.
higher than that now, and I apologize, I didn't bring the numbers in, look at the numbers this morning, but comprehensive is keeping track of those. And unfortunately, part of comprehensive, they weren't able to have a staff person out every single week anymore, due to staffing shortages. So Commissioner Lindy linked me in with Triumph, and so now we have coverage for every week. And it's not just an employed individual, these are people with lived experience who can communicate and really resonate with these individuals and have a better success rate.
I like what Commissioner Curtis said, though, which is accountability. Unfortunately, there's nothing that requires accountability for that.
Well,
I think
I'm sorry.
that's okay. I met yesterday with some peer advocates who people have lived experience are now out in the community to try and treatment center, comprehensive health and other places too, because they know the language, they know the people, they know the thinking. I think those peer advocates are some of the best people to be involved, in partnership with the health district out at the harm reduction programs. I do believe that it's 1-for-1, and I do believe that they need to be engaged with the peer advocate the minute they come in and ask for that. Because that's where the intervention piece goes. And, just speaking general sales, I think most people understand it takes at least 7 contacts to change somebody's mind about anything at all. But we do need to be tracking it. We do need to see how, with the help of peer advocates, and with the help of just one-to-one exchange, how successful are we being in terms of, the use of money for that. So I'm agreeing with your thinking on that. But I also, Melissa, appreciate and the partnerships having, thank you for recommending the treatment services, because they had the peer advocates available, that we have those people on site with our health department personnel for those services.
Is there, I think last time I met with Triumph, the peer support, the issue that they were having was that the reimbursement amount wasn't significant enough, or I don't want to say significant, it just wasn't enough. It wasn't enough to really justify these people taking time off from a job and providing this great community service. So I'm just wondering if there's a way to supplement also, because I do agree that the peer support is something that is absolutely it's advantageous, but it's also because they can give someone hope that there's a better opportunity should they make different decisions.
We did work at length on that issue, and in fact, what we're trying to do is be part of the more collective group, and I don't remember, there used to be a name, but I think it's changed, there's a monthly meeting of the organizations that provide counseling and drug addiction services in the valley, and we want to be part of that, to have some of these discussions. Again, we didn't have the support because it wasn't just a funding issue, it was finding people with lived experience who could do the work. And so I think it's critically important that we have that. And that's one of the reasons we've expanded so heavily into these areas. It's not just a needle exchange anymore, it's much bigger. And so we're committed for it. I do want to say though candidly that even if, and by the way, we do what's called a one-to-one exchange. Other departments don't, they give a will. If someone wants 50, they give 50, but we expect dirty needles to be given back to us because we're trying to reduce the transmission of disease. Having said that, if there was no needle exchange, people would still do drugs in this valley. They would be sicker. They would have more complications. We could have spikes in some very difficult to manage diseases. They would spread it to other people. To your point, Commissioner Curtis, these are not just people who are homeless. They're working in our fast food restaurants. They're working sometimes with our children in drug, childcare centers. They're people that you might not realize you're coming in contact with, which spreads the disease to other people in the community. At the same token, this county suffers a terrible reputation statewide as a drug community. I don't think having needles on the ground and other locations is going to help. I'm very proud of the fact that I don't see needles here. I see needles everywhere I go. Portland, Seattle, Chicago, San Francisco, New York City. I see them everywhere. I see them in parks. I see them on the ground. I've seen them in front of museums. I don't see them here. And I shared that I'm looking for them. I promise you, it's unfortunate. My wife gets upset. I seem to find them everywhere. But my point is that we're attempting to do a community good and also solve the greater issue, which is very, very complex and not ours to do alone. We're trying through partnership to have an increased presence. We're trying to keep track with the fact that people change different sources of addiction, so the different drugs. That's why we want to push for naloxone. And we recognize that there's cities in the lower valley that have this very same issue. So our goal is to benefit more people. But again, I want the board's input on this before we expand.
I think that's interesting that all the cities that you named are ones that are incredibly dangerous, and also it's because of their lax position on drug use. So I think it's interesting you bring those up. I think there are many other communities that you could cite across the United States that also don't have needles on the ground, and they do not provide the same level of lax law and justice aspects to how they work with the community who is choosing to destroy their lives and those around them by using drugs. So I don't think it's as simple as saying that you don't see the needle, that's a sign of success.
I think though that, with the recent decision by the legislature to give a little more teeth to the open drug use law, allowing the county and the cities in the county to look at ordinances that we can use, to tighten some of that up is helpful. But the other comment I wanted to make is in terms of, you mentioned accountability, and I agree and understand with that. That's where the peer support advocates can be helpful because they will develop the relationships. Accountability comes with relationship, and they will develop those relationships, I think, over time with the people that come and use the service. So,
Melissa, perhaps the comprehensive and Triumph programs could give us data of best practices on timing of intervention from their experiences elsewhere and through their organizations. When are people most likely to make change in their own lives? How do we optimize getting people in front of people when they're ready to make change? I'm certain that those organizations can tell you in their own experience, both lived experience and otherwise, there's data on that. And so we should try and optimize not just getting people in front of them, but getting in front of them at the critical times where they might make change in their own lives, because one life changed might have a ripple effect on many lives around them.
And the right timing when they're there every single week and the staff is there and they build those relationships. If someone's ready to make a change, they know they're gonna be there that day, that time. And ready to grab them when they're ready. So that consistency, I think, is awesome.
There's research and data out there to show that people are more likely to enter treatment through certain care programs than those who don't use the certain service program.
Yeah, there's another point which I think we failed to share with you, which is that this program brings people together in ways that they don't normally come together. So having the resources available when someone's coming to get a harm reduction service allows them through a trusted partner to actually have the conversation. Just having somebody available doesn't actually reach people. These are people who live transient lives often, and it's a complicated access point. And in fairness, there are many people who will not seek services through traditional partnership. They just won't. They are very reticent to go to a clinic. They don't want to have somebody telling them what to do. And so this is a trusted resource for them, which is why we want to expand opportunity to do that. Same reason we want to expand discussions around naloxone or potentially support having fentanyl test strips more in the community. This is really about expansion of opportunity for us to address a problem which is deep-seated and very concerning and hasn't showed signs of stopping.
If I could just clarify something. This problem stands on three legs, I think. Needle exchange is one, drug treatment, in other words, treating addiction with drugs like Suboxone and methadone, and counseling and lifestyle changes and stuff. Somewhat independent, but they all contribute to the improvement in people's lives by getting rid of drugs and disease. So without needle exchange, you're going to have hepatitis C and HIV go sky high, which costs a lot of money and is dangerous. Without the drug treatment and counseling really are part and parcel of each other, but not as well developed and integrated as it could be. So that's a separate issue, but all contributes to getting the drug use and addict behaviors decreased. Okay, so let's understand that needle exchange is there and it solves one problem. Drug treatment and counseling are there to solve another problem. And even though they're dovetailed, we need all three of those working to have the best possible outcome.
I just thought it was interesting, it's brought up that we don't have a right to go in and to people's homes and regulate their decisions and what they do in front of their kids and the bad decisions they make, which is valid. I think we don't have that right. But on the other side of that, we should absolutely be staying out of the other side of it and supplying them with the means to continue their bad choices. And that's what this looks like it's doing. That may not be the intent, but that's the end result. And I think that has to be taken into account. And with all of the information, I've worked a little bit with the homeless community, not extensively, but one thing that stood out to me was they are very well informed about what's out there, what's available in services and agencies and where to go. And if they get to a point where they really do want help, they will go seek those out. They know where they are, they will. They're just not as likely to do it when they can go somewhere where they're getting access to more supplies and they're not at that point where they want help. They know they can't go to the other agencies to get that. So yeah, they're not going to go there because that's not where they're ready to go yet. But they are very well informed amongst themselves. They share information, and they know where to go.
Well, unfortunately, there is a reality that not only can you use a dirty needle, but if you know where needles exist, you'll go get them as well. If that means that it's in someone's home, if it's in a family member's home, if it means that it leads to increased thefts because people are breaking in to steal stuff. Those are what people do when they feel they want to do what they want. I'm really sharing with you candidly that this issue was prevalent in our communities long before there were needle exchange programs. This did not begin with needle exchange programs. Drug addiction did not begin with needle exchange programs. it was an alternative to people getting sick. And it's an intervention to ensure that people don't have massive increases in communicable disease. But again, I recognize the difficulties we face here. We also face a reality that there are not enough providers of medically assisted therapy, not enough providers, addiction counselors. You speak to folks at places like Comprehensive, they have long lists of people that they can come into contact to provide services. There's not enough people coming to rural America. This is a problem that we're trying to address. It's an imperfect system.
I could add something. I will freely admit that the needle exchange program on its face isn't something I've ever really felt warm and fuzzy about. You know, but as I've come in and learned a little bit more about it, I've had conversations with Andre and with Melissa about this and trying to figure out really how to make this as effective as possible. And I appreciate Commissioner Curtis's the fact that he's actually gone and looked at it and seen what's happening there. And I'm grateful that we're able to connect, you know, Merit and Triumph along with Comprehensive to increase the Recovery Navigators program's presence in this program. As Andre said, it's not a perfect solution, but if we are expanding, and it seems like there's a reason to expand it, but only if we really do it in a comprehensive manner. So we're not just helping perhaps to prevent the spread of HIV, but we're actually getting people to engage with them every time they show up. So they're having that meaningful conversation to say, there's a better way to live. We can help you with this problem. Please let us help you. And so, you know, if we move forward in that manner, I'm comfortable with it. Not that I think it's a perfect solution, but I think, and again, we do want to continue to track results. We've got to know if what we're doing actually works.
I think that's exactly where I was headed on, right? Is that, you know, I want it to be just as much about intervention as trying to stop the spread. That's the point, because you've routinely said it's just about, you know, trying to keep the spread of disease. And I just don't think it can be just that. We are, as you talk about pillars, have a unique opportunity to engage with these people in that moment and repeatedly be that option, because the criminal justice system has failed in great ways. There is a renewed effort to focus on intervention, but it can't just be the criminal justice system. Every possible, and it's engaging with community members, it's engaging with your family. If there's someone who actually is suffering from this, we have to actually open our mouths and say, this is ruining your life. There's a better life for you. And I do see that this is a perfect opportunity for the health district to be one of those pillars and a way to intervene. So as long as it's about as much intervention as it is about eliminating spread, then I'm in favor for it. But I want to see that tracking, and I want to see the intervention piece be a priority.
When this program first started in the late, well, our program started in 1993, but needle exchange was initially started to because of the HIV epidemic. Since I've come on board, we have completely changed this to a harm reduction, because I believe in that so much, that this isn't about just the exchange of the needle. This is about every other intervention we can do to help these people, as simple as testing them for hepatitis C out there, getting them linked into the liver clinic so they can be treated for their hep C, which will hopefully encourage treatment for their addiction, because now they've cured their hep C. Maybe it gives them more incentive to, quit the addiction, and because they've got something to look forward to now. So it's those little things that we're doing out there every single week. We're benefiting the community by testing and treating for syphilis to decrease the spread of syphilis out there, and then having the peer navigators, I think, is huge out there for us to be able to have the lived experience that our staff just didn't have the expertise in.
And if I may, if you don't mind, Commissioner Lindy, when I first came here, it was strictly a needles. And that didn't work for me. There was no discussion about trying to get people in an intervention. There was no discussion about other opportunities with other service providers. There was no discussion about how people could change their lives. We've expanded it, not because of me, because of people like Melissa. But we entered into relationships to really push that. We worked with the State Department of Health to increase service provision. We worked with the state and the University of Washington to expand the naloxone program in its infancy. We were a test site for naloxone distribution. We worked with law enforcement to ensure that their staff had naloxone if they encountered people. This was really about expanding services. We really encouraged and built what we refer to as the hub and spoke model with the State Department of Health and expanded services through comprehensive. It really has been about expanding to what you're talking about. It's just taken a long time to do so. And I'm encouraged because it's working, I think, and it is a full array of services. And we're finding that in other counties, they're looking to our county as a model because it is so expansive. It isn't just about needle exchange. But we'd like to do more. It's not certainly where I'd like it to be, but also it is encouraging that that location provides an access point for people that are hard to reach. And that's why I'd like to move it into other parts of our county, because there are people living in other parts of our county who are not only suffering from this, but they're also suffering because they have a family member or a colleague, or they're living in a difficult circumstance. Their lives can be improved through those services that you rightly want to see happen, and I'd like to see that too.
Can we make it a decision, a best practice that we won't do the outreach unless that we have someone from Comprehensive or Merit or Triumph on site, so that if it's truly intervention, then I think that it means that we need to have an interventionist there at all times.
I'm comfortable saying that we commit to having those services. I'm not comfortable with saying that if someone doesn't show up, we don't provide the service, because I will share with you candidly that our partners haven't always had the staff. And so I'd like to make a commitment to have that full rounded options, but it hasn't always happened. And my experience with drug seeking population is if you don't provide them regular services, they won't show up. So our commitment, even during COVID, was to provide the service because it was going to lead to more problems. We saw throughout COVID, people going back into addiction. I don't want to see that. We're really trying hard. So my commitment to you is to expand this program, to expand the options, to expand the resources, and certainly to expand the partnerships that lead to more intervention strategies and best practices. I'm absolutely for that 100%, but I will share with you, it's hard because we're working with partners and our partners sometimes don't have the staff, which is why we've expanded to other programs. I mean, rather other partners to support that.
I don't think it's impossible to do, and you can write it contractually. I'm only going to support it if the intervention is absolutely there at every time.
Well,
Perhaps so we could, if Melissa was mentioning the fact that the stipend or whatever isn't enough, maybe we could supplement the stipend to make it enough to where you get 100% participation. I mean, because that's a
point.
fixable problem at that
We
point.
can, and I'm willing to invest in that. I think we're talking about two different things. Well, we're talking about three issues now. We're talking about the value of having a harm reduction program. We're talking about expansion into the lower valley, and then we're talking about these contractual services, which we can work on, and I'm not against that at all. In fact, that's one of the reasons we have resources. So if we're looking at having something consistent, that's great, and I'm certainly supportive.
I think we can all agree that we want the interventions out there every time. I think what I'm saying is that if someone doesn't show up because someone called in sick from another agency, we just can't control that. But the intent is to have someone out there every single week from these facilities.
It just needs to be documented. Intent is great, but when you're talking about going through an actual service that you're providing, you know that you can set certain expectations for what conditions are present in order for you to offer the service.
Well, I'm very encouraged. There have been years in the past where this board, and I don't mean the individuals on this board, but this board as a body was not supportive of spending money on these programs. So if we're talking about contractual obligations, expanding these programs to ensure that people show up, I'm very supportive of that. I'm excited about that.
So Andre, you started off with this conversation talking about 3.5 FTEs and some resources. So we have the folks and we have the money to expand this program into the lower valley.
You do.
Okay.
What will take time is finding a location.
Yep.
And in fairness, we don't want to impose ourselves on our communities. So we normally have conversations with the city council and the police chiefs and so forth, so that it's encouraged. Do you want to share what we did last time?
Yeah, so 2019, we identified a site in Toppingen. We had with someone really interested in helping us expand, and we met with the city manager, with the police chief, with the fire chief, and other city representatives. And they actually went to their city council and was approved for us to expand. Shortly after that, the owner decided that he was thinking about selling the property, and so that got put on hold, and then COVID hit, and so that's where it was left off. But we
I
did.
think you're gonna
approve
have
through-
broader support, honestly, across smaller communities. If we can represent this to be as much about intervention and saying we are going to have an interventionist there.
Yes, and I'd like to have dedicated space so that we're not dependent on that. I don't want to be dependent on the owner of a property who then sells the property or who decides that somebody showed up and they don't like that person, so they don't want the program anymore. I'd like to have consistency. One of the reasons we're talking about having a dedicated space partnership with either clinics in the lower valley or cities in the lower valley is so that we provide that consistency that you're talking about. We have to have that consistency in order to make this work. And that's why we're committed to doing it. I like the direction that you're giving us. I did want to share with you candidly, though, that it'll take a few months to figure out locations, partners. You know, we have wonderful partners, and actually, these are conversations that we've had with other groups like Neighborhood Health. It's dedicated to working with the homeless population, the Union Gospel Mission, and others. And it's exciting that there's a collective effort happening in the valley. So over the next few months, we'd like to come back to you with our progress on some of these discussions. In fairness, though, some of those discussions at some point become more public if we're talking to cities about, you know, providing a service in their communities. I just want to forewarn the board about that.
Are you looking for a motion from the board or anything, Andre, or is this conversation good enough?
I'm fine. I mean, these are robust conversations. I want the boards to be, I want each member of the board to be heard if there are concerns. It doesn't always have to happen in a board meeting if people want to call us and discuss things with us. My greatest interest is making certain that we are in agreement with moving forward. The specifics of it, we can certainly continue to work on. And the investment that we make on things like contractual relationships, that's very encouraging. I mean, I'm happy to spend money to make certain that people show up to do their job. It's actually quite frustrating for me after building all these things and then it doesn't happen. It's upsetting for me, to be quite candid. These are very serious issues, and reaching somebody when they're ready is critical. Reaching somebody when they feel confident, trusted, supported, that they're ready to take a tremendously difficult change to their lives. That's asking a lot. And when people don't show up, it's upsetting to me. I mean, we don't expect that of our staff. That's the difficulty of working through partnership. So if we can commit through contract and spending money, I'm very encouraged by it.
I would just say that I'd like to see on our next agenda then, a discussion though about youth prevention. And especially targeting fentanyl. Because I think that, you know, it's very clear that we spend a lot of resources as a community on the end result of someone becoming addicted. And I think that we just don't put enough heavy emphasis exposing our community, especially our youth, to the dangers and where it will lead. I know that there are many organizations locally who would do that, and I think that it would be worthwhile the health district investing dollars into youth prevention.
Well, you know, one of the things we've talked a lot about is that we try to incorporate a catalyst model where we identify an issue in the community, a need, partners, and then the costs and funding. It's not the health district necessarily doing it, but it's the health district driving it, the health district paying for it. I'm very encouraged by that. We can work with groups like ESB 5 and others to do that. And these are serious issues. I would love it if every single child grew up without wanting to test out addiction. I would be very happy. So that's encouraging as well.
Commissioner McKinney, I think too that your suggestion that we're not on TikTok, we're not reaching them, and working with ESD or somebody like that who can take care of that too would be pretty phenomenal.
Lillian did not catch me.
I was gonna say she's smiling because she's ready. And this is one of the exciting things, and I didn't want to keep candid, but one of the things that we did through COVID around communications that have become models for the community, and I'd like that to continue so that this can be a replication site for the entire state about how you reach a community in a rural area so that you provide them with the best resources.
So on the topic of youth intervention prevention, well, prevention really. I was at a meeting yesterday in Sunnyside for Sunnyside United Unidos, which is exactly that. It's a youth, drug and alcohol prevention program. And they're making progress there with what they're doing. I think they can do more, but I was encouraged by what I heard yesterday. And there are other communities like Ranger, White Swan, they're based on school districts. I think there's a lot of potential there. I was talking to the superintendent after the meeting yesterday, and said, this is a good start. I think based on what I heard, there's more you can do, fairly easily, but do you have a relationship with these groups?
Yes. So those are the community wellness prevention initiatives. And so those are all, I think you serve on the board of one of them as well, and Hyatt. And so those are groups that we're already connected with through our youth marijuana prevention program. And so we can happily, and that's exactly what I wrote down in terms of next steps on reaching out with that direction. Yes.
There's a lot of potential. It was kind of funny. Part of the meeting was, and I know we're over time here, but they had presentations by elementary school kids, which were great. They really were, middle school and high school. So it's throughout throughout all the grades. But one of the things they did, I think with the middle school, they had this video presentation about, the deadly nature of fentanyl. And they've taken the ideas that, well, we're going to invite kids to come to this, for a lunchtime program. And I said to the superintendent yesterday, it was great, but you got 42 kids and you have, 1,000 in the school. Why don't you just have an assembly, and show it to everybody? He says, great idea, so I mean, these are the kind of things we got to think is like, let's, we could target a few, but we could hit everybody if we do it right.
On that note, I think it would be beneficial to invite someone from ESD 105 to participate in this conversation next month to really make sure we have someone at the table that will understand how, if we are going to throw money into this effort, what program is going to get the biggest bang for the buck.
I would suggest that Lupita can offer a lot of advice on how we can work on it.
Yeah, I just wanted to comment that the ESD 105 region has many community coalitions that are youth focused and family focused with specifically on drug prevention and abuse. And so one of ESD 105 region would be great. Like someone from there would be probably offer some great input, but you would be surprised that even though these community coalitions are community driven, and oftentimes they have great support, but they're not always incredibly supported by the school districts. So there's some ways that I think that the health district can probably partner, and they can always use a lot more support. So there's many in the ESD 105 region, there's many in the Yakima County, and sometimes their efforts are overlooked. And so this is a great conversation to be able to see what do they need. And if there is opportunity to be able to even influence a little bit amongst other organizations that the health district works with, then I think that this is a great start.
Well, we're encouraged by that. We did a lot of work with community interventions that weren't just through traditional partners. The other thing that I'd like to share is that we can spend some time researching best practices. It's one thing to communicate. It has to be on the right platform, whether it's TikTok or others. And it also has to be the right message. You can spend a lot of money communicating, but it doesn't reach people, or they don't have any interest in it, or it's not in the correct language, or it's not written for them to understand. It isn't going to win. And so, the Just Say No to Drugs campaign, it didn't land.
That's not true.
Well, no, but what I'm trying to get at, what I'm trying to get at is.
Product to dare, I mean.
I was
every time
too.
someone
I
says
was
it didn't
too.
work, not
But
true.
guess what? We were also encouraged by our parents to not do these things. I'm sharing with you that we have to be able to reach people at all levels of their interactive goals. And that's the thing that's missed. And so, I just want to reach people at all levels. Not everyone who's going to come to the assembly is going to be at the assembly. So I want to reach people through social media. I want to reach through peer-to-peer networks. I want to reach people through coalitions. And one thing we haven't talked about is, and I want to be careful with this, but people have strong relationships with their religious affiliation, their fellowship. AIDS was a huge issue for many, many years, and it went undiscussed until churches got involved and said people were dying and this was preventable. We can also have those conversations with people about how they can encourage people through their social networks, their peer networks, their religious networks to do so. It takes money, but also it takes best practices. So I just want to share with you that we don't want to spend public dollars on something that doesn't effectively reach people.
So the nice thing about communicating with teenagers is that it actually isn't expensive. And I would actually say that Lupita probably has some very good contacts of some students who volunteer who would be able to have probably, I don't know, 5 minutes, they could create content that Lillian could use, I just think that it's probably, again, it's not expensive. It's just the messenger and the platform.
I was thinking we could get our local rapper Coaster up on some TikTok pages.
Trisha.
You know, LaDon, I might suggest that the kids that would show up at the assembly are not the ones you want to reach. It's the ones that are doing drugs behind you. But you're actually, however, the idea is good. And I think that a lot of government agencies recreate wheels when in actuality, there's perfectly good wheels. You just have to fund them. They never have funding. And so you throw some cash at problems that will help.
And
So, but we can only use TikTok for a while, because then it's gonna maybe go.
Well, TikTok might not help you though, because fentanyl is marketed by the Chinese government who also has TikTok.
Larger conversation
no.
that we need to have as a nation.
The only other piece to this is we do have people who are kids who are suffering through depression and also self-harm. And so there are ways to reach kids through social media and opt-in platforms that allow them to stay safe as they get to adulthood. So I'd like to have this as part of a larger discussion about reaching people that way. Thank you.
All right, thank you, everyone. A great conversation today. We do have one more category before adjournment, and that is new business. And today, the new business is Narcan vending machines to help deter overdose deaths. And Commissioner Curtis has.
Yeah, and I think this will probably just carry over into next month's meeting. But I had asked Andre if I could add something to the agenda. And I'm just throwing this out there for folks. So I've been struggling the last 3 months with when I heard the stat that Yakima County has the highest percentage per capita of overdoses in Washington state. And that has always stuck with me. And I've always questioned myself of like, what am I doing? What is the Board of Health doing? What are we doing as a county to help curtail that and make measurable progress in stopping the amount of overdoses? I did a ride along with the city of Yakima Fire last week, and they said that on average, they have 7 calls a day, not just at night, but during the day, in which someone's experiencing overdoses. That doesn't always equate to death, but nonetheless, it is a big issue in our community. Speaking to the coroner this morning, it sounds like we had 3 fentanyl deaths just this weekend. So this is a big issue for the county, and I can't help but think that this board is probably the best place to have these types of conversations of what can we do as a health district to try to put an end to this epidemic. One thing that I saw that some counties were doing across the country was the idea of Narcan vending machines. And at first I was like, well, how big of an impact can that happen? Can that make? Looking into it further, there has been quite some success with Narcan vending machines as far as getting Narcan to certain populations in our community that otherwise are not going to get this added resource. I know in 2019, the state and our governor made it a big push to make Narcan readily available. But just the other day in the Herald and Seattle Times, they put a post that says or an article that said that's just not true, that you can't just walk into your Rite Aid and walk out with Narcan. It's really not that accessible. And in fact, the state's website that's supposed to show you all of the locations in your county of where you can get Narcan only show 2 in Yakima. And I know that that's just not true. So I'm not saying Narcan vending machines are the answer, but we've got to do something. And so I know we're short on time. Maybe this is just planting the seed for a bigger conversation next month of what can we do as Board of Health to really hopefully stop the upward trend. So I'm just putting that out there.
I think it'd be good for a longer conversation. What I would just add to that is that I see it in the same way as I see AEDs and businesses. So I think a first approach for me would not necessarily the vending machine, but I would like to see us work on programmatically doing business outreach. We're already in their business anyway, doing inspections for a lot of them, but I think somehow equating it to the idea of having on site in businesses where it's something that is readily available, and unfortunately, because it is in public spaces. And I think, you know, if you have a heart attack, you're hoping that they have an AED, and I think if there's an overdose in the McDonald's, we would similarly hope that they would have their on site. And just one other thing to add to next week, if we're going to carry that, is that I do know that there's been some requests through Camp Hope, and UGM for donors to purchase Narcan. And I'd also like to just encourage staff can look into if there's a way for us as a health district to provide Narcan to UGM and Camp Hope, rather than having to go out and, try to purchase it with donor dollars.
Well, I have some updates on that if you don't mind. The vending machine is interesting. But the question becomes, who buys the vending machine, who staffs it, stocks it, who purchases the supplies? I've done some research, and currently the Accountable Community Health that's in the region around Grant County, Shannon Douglas County has purchased some, so I'd like to inquire about that, the cost related to who's running it. We're talking about places like really rural parts of those counties, which is interesting, because again, we would be talking about something similar. I believe the idea is that they're looking to place it in a location that's observed, so that it's not actually stolen, or that one person gets all of them. I don't know how that works. In fairness, I also have read nationally that there has been success in placing these vending machines in jails, not in the jail itself, but in the common areas, so that when people are leaving incarceration, they have access to it. When their family members come, they have access to it, which is encouraging, because again, we're talking about trying to find people.
Right now, they need it in the jail.
Yeah, in the jail.
Well, and
We linked the county jail to the State Department of Health to be able to get their own Narcan, so their CO should have that.
Oh, no, we actually do have it in the jail, but I'm just making reference to the fact that unfortunately it's getting smuggled into our jails, and there were 5 inmates who just died of fentanyl overdoses in Snohomish County last week, so it's just.
well, and that's one of the reasons that we worked on getting these services available, because it is expensive. It's not cheap. It's not $1. So before we talk about the health district investing in these, I want to be very honest with you about cost, because you could be talking about many tens of thousands of dollars. It doesn't mean it's not worth doing, but it's also something that has to be replenished. And as an example, we worked with law enforcement here when we first started talking about naloxone, because you don't want to place that on the dashboard of your car in 120 degree heat. It becomes ineffective. So it's got an expiration date. It has to be temperature controlled, not to a great degree, but it can't be left in the sun. We're happy to work on this, and we're encouraged by this. And so the vending machine concept is an interesting one, because again, it means people have access to something that doesn't have to be staffed all the time. And if we could do that through partnership, I would be happy to look into that. So we'd like to get more information for you for next month. Unless people.
To a business community.
Well, and we've worked very closely with the Chamber of Commerce as well, so there's no reason why we can't do that.
But I like Commissioner McKinney's thought of like, is there a little kit that we could purchase that could be placed in businesses and in schools even, readily accessible to grab and access and use? I think that's an interesting.
Schools do have it, Melissa, but I don't know. Yeah, the problem is, and Dr. Barr can speak to this too, as well as our coroner and our law enforcement. Unfortunately, one dose is increasingly not enough. It's, 3 or 4 doses are what it's taking.
The kits that we distribute are 2 doses.
Yeah.
And Lillian's actually working on a great campaign. I love this conversation and her campaign, because in a couple of months, Narcan will be available over the counter.
Yes.
So you can just walk in and get it. So she's actually, I don't know if you want to talk about that, the work that Jocelyn's doing.
Yeah, so next month actually is perfect timing where we can talk more about the multi-pronged approach, where it's not just communication, it's not just where you can actually access it, calling all the pharmacies, making sure that they have it on hand, making sure that they're gonna follow the best practice to make it readily available, but also working with the businesses, because it is impacting everyone in our community. And so it's not just a communications piece, but it really is a second step to the communications that we did last year, and making sure that now that it's going to be that it should be readily available, that we can actually move forward with making that a reality here in our community across Yakima County. So
Help these local pharmacies or retail stores to make sure that they have it on their shelves. What's the barrier? Yeah, how can we help them?
Yeah.
more to come.
Yeah, I do think there's a community widespread energy around this, in the sense that not everyone, and because it's still gonna have a cost. And so I do think, and I don't know what our opportunity as a health district is to accept, sounds like we can accept donations, but I'm just wondering if there could be a little bit of community crowdsourcing to help purchase these for folks who maybe want it in their business or home, but the cost prohibitive. They might not, so they do think that there's some opportunity there for the community to show that they want to have other people have access to it and not have a financial be an issue.
I'd like to look into the cost. There are some times where we have access to very inexpensive costs as a government agency. There were times where we were not allowed to distribute. We could only use it, we could only distribute ourselves. And so if we can be a vehicle for that, then I'm very open to that. I think we'll have access to resources for that. So before we ask for donations, I think it's more appropriate for us to just find cost and then.
Sure,
get back
sure.
to it. But again, very encouraging conversation. So thank you.
Anything further? If not, then I'm entertaining a motion to adjourn.
So.
Okay. We have a motion and a second to adjourn until our next regular scheduled Board of Health meeting on June 28th, 2023. Thank you very much for being here today.